You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 15th, 2019, and today we're talking cost of cardiac care, adherence to statins, syncope, ultra-processed food, and heart failure survival. So the cost of heart care in the U.S. is the first topic, and despite the strength of the U.S. economy, many of our citizens struggle to pay their health bills. Now, I realize that for those of you listening in countries with national healthcare systems, this sounds nuts. And to make matters worse for the millions of Americans who have high bills from cardiac care, is that a lot of the care we deliver is flat of the curve, low value, expensive care. But, crucially, some of it is not. And when out-of-pocket costs are high, this may push people to forego important therapies out of financial considerations. Yale researchers from Harlan Krumholz's lab studied the burden of financial hardship from medical bills among patients with heart disease. Specifically, they measured the potential consequences of these bills at financial distress, food insecurity, and medication-related non-adherence. JACC published their study. They used publicly available 5-year data from 2013 to 2017 from a national survey that studied more than 164,000 people. And not surprising was that the cost of managing heart disease is huge. 45% of patients with heart disease who are younger than age 65, and that's important because that's the age when you can get Medicare, or nearly 4 million Americans reported financial hardship from medical bills. 1 in 5 patients with heart disease, or almost 2 million nationally, are in families reporting receiving medical bills they cannot afford to pay. The researchers adjusted for confounders, and they found that those who reported an inability to pay medical bills had higher odds of high financial distress, food insecurity, and cost-related medical non-adherence. And hardest hit are the uninsured, but sit down for this. The vast majority of individuals with heart disease reporting problems paying bills and paying them over time are insured. Yes, insured. The fact that having medical insurance is not preventing financial distress is what sets this analysis out from previous studies. I had a patient recently who had insurance. She was on 3 medicines controlling AFib, 2 of which, the anticoagulant and the antiarrhythmic, will cost her over $400 per month. This is crazy. These are everyday medications to control a common condition. Healthcare costs are going to feature in our upcoming presidential elections, and we need change. Number 1, I think we need to do something about the high prices that are charged. We need to reduce the burdens of high administration costs. For instance, I've had a number of super elderly patients come in for shortness of breath, and all of them had $1,000 echocardiograms ordered, even though they had an echo a few months ago. And when I asked the doctors why, they said that echo was needed for quality measures. My friends, this is administrative burden run amok. Then I think we need to talk about covering everyone. Now, this will require discussions of trade-offs. And I hope that the current talk of Medicare for All will force public discussions about the trade-offs of these different approaches to solving these distinctly American injustices. Second topic, statin adherence. If you have established heart disease, statin drugs reduce the risk of having another event. But that's only if you take them. Stanford researchers wanted to determine the association between statin adherence and mortality in patients who had heart disease, e.g. secondary prevention. They performed an observational study of nearly 350,000 veterans, so in the VA system, who had stable statin prescriptions between 2013 and 2014. They measured adherence by the medication possession ratio, which is an accepted but imperfect measure. JAMA Cardiology published the study. And importantly, patients chosen for the study had to have stable statin prescriptions, which reduced the amount of poor adherence due to drug side effects. So they found that patients taking moderate intensity statin therapy were more adherent than patients taking high intensity statins, and the odds ratio there was 1.18. The young and the very old were less likely to be adherent compared with adults aged 65 to 74 years. And there was a graded relationship with the least adherent patients having the highest adjusted hazard ratio for death, 1.3, while the most adherent had the best adjusted hazard ratio for death, or lowest, at 1.08. Now, of course, this is an observational study and there are likely residual confounders. Patients who adhere to medicines may have other reasons besides statin use that give them better outcomes. The authors could not account for cause of death, and you would have only expected CV death to be reduced. So this is kind of important because if you had a reduction in death without reduction in CV death, that would suggest that the association is confounded. Nonetheless, this study argues for thinking about adherence, especially in patients most likely to benefit, such as those with known heart disease. Next topic is syncope. Canadian authors studied about 5,000 patients who presented to emergency departments with syncope. Circulation published the observational study, and I highlight it because syncope is so common, and its workup requires good history taking, thinking, and clinical judgment. Robots, for instance, would be terrible at syncope. The authors sought to find the optimal duration of emergency department and post-emergency department cardiac monitoring among patients with syncope. They used the Canadian Syncope Risk Score, CSRS, to help categorize risk. Now, this is the key thing in syncope. You have to decide, was the event an aborted cardiac arrest due to VTVF or something like heart block, or was it a benign condition like vagal or low blood pressure? The majority of patients in this study, 74%, were classified as low risk, 19% medium risk, and 7% high risk. The main finding was that the overall risk of events in patients who score low on the CSRS have an extremely low but not zero rate of events. However, importantly, no low-risk patient had death or ventricular arrhythmia. When low-risk people had an arrhythmia, which is about 0.4%, it was identified in more than half of these patients during the 2 hours of monitoring in the ED. And for medium to high-risk patients, most of the arrhythmic events occurred in the 15 days after presentation. And the authors felt that their findings support brief monitoring in the ED for 2 hours in low-risk patients, 6 hours in medium and high-risk patients, followed by selective admissions, as well as 15-day outpatient monitoring for medium-risk patients at a selected thresholds and certainly all high-risk patients. Now, the problem with this study, which the authors mention, is that 6% of patients were lost to follow-up. And since syncope in low-risk patients is an asymmetric risk, what I mean by that, yes, there's a tiny chance of a low-risk patient having a bad outcome, but one bad outcome, it could be super terrible. For example, a missed problem in a young person, so incomplete follow-up is a serious problem. Though I like this study because it highlights the need for thinking and not over-testing patients with syncope. My approach to syncope is really fourfold. You have to get a detailed history from the patient or family. Details, they're key. For instance, stone-cold syncope without warning and with injury should get your attention. Second, you have to think. What company does this syncope keep? You have to think about the past medical history, the past cardiac history. Third, I study the ECG, especially the QRS. Notched or fragmented or broad QRSs should make you nervous about higher risk. Now remember, vagal syndromes often have a long QT right after the event, and so check another ECG a few hours later. I see a lot of overdiagnosed long QT after vagal episodes. And finally, you have to remember the base rates. Vagal episodes and low blood pressure as causes of syncope are most common. Next topic, ultra-processed food. This is defined as food that is made industrially from multiple ingredients that usually include additives used for technological and/or, get this, cosmetic purposes. Ultra-processed foods are mostly snacks, desserts, and ready-to-eat hot meals, and they're almost always energy-dense. Now, French authors asked whether or not intake of these foods associated with an increase in risk of death. And they did an observational cohort study over 7 years looking at 44,000 people who self-reported their food intake and were older than age 45. And I know, not surprisingly, ultra-processed food intake associated with younger age, less physical activity, lower education level, and higher BMI. And after they adjusted for variables that were known to affect mortality, the authors found that an increase in the proportion of ultra-processed food was associated with a higher risk of all-cause mortality, and the hazard ratio per 10% increment of UPF, ultra-processed food, was 1.14. Now, there was another study published recently from Kevin Hall's group at NIH, and I'll put the hyperlink in the show notes. They were interested in establishing a causal link between ultra-processed food and obesity. This was an RCT in 20 weight-stable young volunteers who were admitted to the NIH center and randomized to either an ultra-processed or unprocessed diet for 2 weeks, immediately followed by the alternate diet for 2 weeks. They gave them meals were designed to be matched for calories, energy density, macronutrients, sugar, etc., and the subjects were instructed to consume as much or little as desired. Energy intake was greater during the ultra-processed diet, over 500 kilocalories per day, increased consumption of carbohydrates in the ultra-processed diet, as well as fat but not protein. Subjects gained 0.8 kilograms during the ultra-processed diet and lost 1.1 kilogram during the unprocessed diet 2 weeks. This is the same dose of food, but more carbs, fat, and calories, and weight gain. They concluded that eliminating ultra-processed foods from the diet decreases energy intake and results in weight loss, whereas large quantities of ultra-processed food in the diet increases energy intake and leads to weight gain. Now, the reason to highlight the observational study and this small RCT is that ultra-processed food represents low-hanging fruit in the nutrition counseling discussion. Given the importance of weight loss for obese patients with atrial fibrillation or other heart disorders, I don't think we need to overthink our nutrition advice. Much of what we can offer is simple advice. For instance, I tell patients cut back on these processed foods, especially ultra-processed foods. Get out of the middle of the grocery store, reduce that food. And just doing that will help the vast majority of people that I see, help them to lose weight. Final topic today are trends in heart failure survival. So primary care researchers in the UK looked at survival after a new diagnosis of heart failure in patients older than age 45. The BMJ published this study, and this was a population-based cohort study of 55,000 patients in UK primary practices. They found that survival after heart failure diagnosis gradually improved over a 17-year period, but the big story was that there was extremely flat amounts of survival changes. Basically, 1 in 5-year survival after a diagnosis of heart failure was about the same in year 2000 as it was in 2017. Not surprisingly, those in the lowest socioeconomic group survived about 2.5 years less than those who were better off. The authors point out that the gains in survival over the 17-year period, which was about 6%, are being surpassed by gains in survival in cancer. And the authors highlight the importance of access to echocardiography and BNP testing and early referral to cardiology. But my American take on this data is that we should not expect big gains in survival after a heart failure diagnosis, and I would argue that a 6% increase is pretty good. Now, here's why I say this. Patients diagnosed today, at least in my clinic and most American cities, diagnosed with heart failure rarely have heart failure alone. They have multiple comorbid conditions, and combined with the fact that people don't live forever. So, yes, of course, mortality is an important metric for heart failure, but I think in heart failure we need other metrics too. We need quality of life measures, And I think the biggest problem in heart failure care is that it's too often guideline driven, and this makes it heartless, like heartless heart failure care. We worry so much about checking boxes, and we worry not enough on palliation of symptoms such as helping patients with dyspnea, edema, and even anxiety. So my hope for the future is that heart failure care becomes less heartless. So that's it for This Week in Cardiology. I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider subscribing, giving us a review so that others can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.